and it's a long surgery. What they'll have are little bladders that goes over your legs, right? That inflate and deflate, inflate and deflate. Why? It's activating your skeletal muscle pump. Now, remember, when you were talking about the skeletal muscle pump, that's only good for the deep veins of the legs. The superficial ones, like the great saphenous, the small saphenous, they're so superficial that no matter how much you try to contract those muscles, the blood moving through it, most of the time, it's not going to move through quite as easily. And that's why some people have varicose veins, some of them have spider veins as a result of this. Is because the blood that should be going through, for some reason, isn't going through. And now, all that blood is heavy, it starts stripping the valves. And because the valves are no longer working, now it's hard for the blood to move even more, all right? Even more difficult for blood to move. Now, usually that doesn't cause a blood clot. That's good news. You don't have a lot of symptoms when it's your very, very superficial veins like the great saphenous and the small saphenous. It's not going to lead to a thrombus or a pulmonary edema or pulmonary emboli, right? That doesn't happen. It's the deep veins that we're worried about for those conditions to happen. In terms of varicose veins and spider veins, those are usually more cosmetic. So I say cosmetic, but you'll see people just completely not wanting to wear shorts as a result of it. And after a while, it might even start to hurt. Blood pressure and effect on gravity. In a standing position, hydrostatic pressure caused by gravity increases blood pressure below the heart, decreasing pressure above the heart. Right? Meaning that if I would take your blood pressure in a sitting position on your femoral artery, right, blood pressure, you will always have high blood pressure. The reason why is because we'll always have higher pressures, about 10 to 15% higher when we're measuring it below the level of the heart. By the way, this is why when you're taking blood pressure, or when somebody's taking blood pressure on you, right, and they have your arm just straight down like this, right, what happens if your arm's straight down and you're leaning to one side is that you might have an artificially higher blood pressure. So I want to make my blood pressure as low as humanly possible when they're measuring it, right? Insurance. So what happens? Right? I keep my arm elevated on the actual table, and a nurse should actually hold it up while they're taking the blood pressure. You should hold it up so then it's at the same level as your heart. Right? If it's downwards a little bit, even that little bit of a downward, movement right there might cause you to have an artificially high blood pressure. That's enough. Especially if you're on the borderline, right? If you're normally 125, and now that little bit makes you 135, well, what happens is, if you say you have high blood pressure at that point, your insurance rates are going to go up. So, you want to make sure that you really do have high blood pressure. Local control of blood flow in tissues. Now with this, again, big thing is local control is proportional to the metabolic needs of the tissue. Meaning the more active the tissue, the more oxygen it picks up, right? The more oxygen it needs, the more oxygen it will pick up. Kind of like that, that picture that I had shown there before about what happens when you have an active tissue. When you have an active tissue, inside, so thick skeletal muscle, inside the skeletal muscle, when you're working out, well, you're working out, you need energy, right? So you're going to need oxygen, you're going to need glucose to keep driving those contractions. So what happens? Well, inside the cell that's active, you're going to have low oxygen, low glucose. It's a sign of activity. Again, sign is something that you see, and we can see and measure that low oxygen and low glucose level. So what happens then? The active tissue that's systemic will have low oxygen, low glucose, meaning now there's a concentration difference for both. You can have high levels of both in your bloodstream. High oxygen, low in the cells. Oxygen's going to go right through. All right, high glucose in your bloodstream, low in your skeletal muscles. Glucose is going right through. Perfect. Now this is seen in systemic circulation. Nervous system, responsible for routing blood flow and maintaining blood pressure. So besides local control of the tissue, we'll also have the nervous system controlling it, meaning that they should all work together, right? So if we're working out, the sympathetic nervous system should be kicking in. At the same time, you should also be having this local effect where we have more blood flow and more oxygen and glucose going to your muscles that are active. So they're working together. So what do we see? As part of our cells and our body working together as a whole, right? Is this. The nervous system, when you're working out, sympathetic control increases, increasing blood flow to the skeletal muscles. At the same time, when you have more sympathetic output, your celiac trunk, because of the sympathetic activity, the celiac trunk starts to constrict slightly. So does the renal arteries, right? So does the gonadal arteries. So does the superior and inferior mesenteric arteries. All of those areas, the blood vessels there constrict slightly. So then we can detour blood away from those areas, right? So then we can have more blood going to the skeletal muscles. Again, keep in mind, right? All of our blood vessels are only innervated by the sympathetic nervous system. So you'll either have increased sympathetic activity or no sympathetic activity. So when you are resting and digesting, no sympathetic activity. What happens? In the GI tract, because of no activity there, right, because you're resting and digesting, there's no sympathetic output. Celiac trunk then dilates. Superior mesenteric artery dilates, right? All those blood vessels dilate in response to no sympathetic output. Now I say no, but we're really saying some low levels of it. Right. Hormonal control also can be traced to the nervous system and epinephrine and norepinephrine. Remember, sympathetic nervous system will cause you to release norepinephrine and epinephrine. So again, all of these having an additive effect. So if you're working out, you should have norepinephrine and epinephrine release. All right, it can give you that kind of high that people get from running marathons. I don't know why you get a high from running marathons. People are crazy, right? But they do. But that's a release of the epinephrine and norepinephrine. What else? The weird thing is epinephrine and norepinephrine has different results depending on where we release it. Meaning what? If I put, right, epinephrine in the blood vessels, in your skeletal muscles, in the lungs, in the brain, right, it's going to cause vasodilation. We see this all the time, right? What do you give somebody when they have an asthma attack? Albuterol. What is albuterol? It's very similar to epinephrine, right? Except it's localized in the lungs. Albuterol is a beta adrenergic. So is epinephrine. The big difference is with epinephrine, you shoot it into your blood vessels and it goes systemic, right? With albuterol, it's like an inhaled form of epinephrine, right? It does the same exact thing, but since you inhale it, it's localized in the lungs. And it causes your bronchioles to dilate and your pulmonary arteries to dilate, allowing more blood flow and more airflow. Right, here's just showing what happens when we have the local control. Now keep in mind, right, when we talk about active tissues, right, that's systemic tissues. There's always that dichotomy, difference between systemic tissue and lung tissue. What happens in lung tissue if the lung area has no oxygen? Is that a sign of activity? No, it's a sign of damage, right? It's a sign that something's wrong in the lungs if there's no oxygen there. So do we want blood to go in that area where there's no oxygen? When it's in the lungs, no, right? Because low oxygen in the lungs, sign of pathology. Low oxygen in the systemic tissue is a good sign. It's a sign of activity. So you want to bring blood in those regions that's active. So in systemic tissues is different than in lung tissue, pulmonary tissue. To review these right here, what can cause this relaxing or constricting of the sphincters. We're almost done. Once we're done here, we'll take a little break. I was gonna go downstairs and get it, and I forgot my keys, so I gotta come back up here and I'll go back down again. Now this is crazy. Blood flow can increase to 7 to 8 times normal levels because of vasodilation of the arterioles. Think about 7 to 8 times the normal values. Long-term local control, capillaries become more dense in regions that are regularly has increased metabolic rate. So what happens? The more you work out, the more changes. Now, if you work out for a long, long period of time, for years, right? And again, when you work out for years, it doesn't mean you work out continuously for years. Even if you take a month off or so, right? That's still, you come back, that's still a pretty good thing. What happens is when you work out for that prolonged period of time, we see some massive changes in the blood flow. We actually add more capillaries there. We'll make more anastomosis in those regions. So then we can bring more blood in those regions. Again, kind of makes sense because when you work out more, you get in better shape. You also are able to exercise longer. Why? Just because you have increased capillary density, increased blood flow, increased fuel, so then you can maintain that activity. Nervous control in the tissues provides a means by which blood can be shunted from one area to another by increasing the resistance, basically by vasoconstricting or vasodilating. It looks like a brand new slide, but it's basically telling us things we've talked about previously, which is we control by the nervous system where blood flows, right? Sympathetic nervous system, more blood flow to the muscles, to the lungs, to the brain, to the heart. Sympathetic nervous system, right? Most important, innervates all blood vessels except capillaries. Capillaries, you just move blood through, right? They're either open or closed. If they're open, you move blood into the capillary bed, you'll have nutrient exchange. If you don't want nutrient exchange in an area, you just close the blood flow by activating the sphincters. That way you detour it away from the capillary. Excitatory part, all right, so vasomotor center is found in the lower pons and upper medulla oblongata area. Again, and here you guys thought you probably had to, you can forget about 201. So the pons and the medulla, again, cardiovascular center and respiratory center, right? That's what we talked about for the medulla oblongata. That's what makes it so important, right? Well, with the medulla oblongata, excitatory part right here is tonically active, causing us to have vasomotor tone, setting blood pressure. Remember how I told you guys in 201 what happened to Dale Earnhardt when he died? When Dale Earnhardt died in Daytona, he had an internal decapitation of his skull. The dense process went up through the foramen magnum and destroyed the medulla oblongata. At that point, his blood pressure went to 0. At that point, he would have passed out immediately and hopefully died within a few minutes, right? That quickly because the blood is not moving into the brain. Well, all right, the good news is he would have been passed out, right? He's not hopefully feeling that sudden pain as a result. Inhibitory part can cause vasodilation by decreasing sympathetic output. Again, lack of sympathetic activity dilates blood vessels going to your parasympathetic nervous system, right? Come back to that in a second. Well, I mean, you guys better get this right by now, right? MAP, mean arterial pressure. What makes it so important? And some of you guys got this right. This is a pressure that allows us to perfuse. It's also called a perfusion pressure. You need a minimum 60 millimeters, right, to 70 at birth, right, of MAP for us to perfuse all of our organs. That's what why MAP is so important. It's the only time where we see that we want blood pressures to be a little bit higher. Normally we want the blood pressure to be as low as possible. MAP, we want to be slightly higher. The higher the MAP, the more we know we're perfusing all of the great organs. Was that? Yeah, I already got some of you guys.
I did.
Mm-hmm.
I
You still have the diastolic one to write in. We'll see what you get right.
No, you always turn it.
So baroreceptor reflexes right here, change peripheral resistance, activates with sudden increase or decrease, And the thing with the baroreceptor reflex, right, it doesn't fight off high blood pressure. So they talk in the book about with the baroreceptor reflex right here, it notes a change in blood pressure, increased blood pressure. Then it causes the vagus nerve to activate. Again, the vagus nerve only goes to the SA node. Since it goes only to the SA node, you can only affect heart rate as a result. So with the increase in blood pressure, the only thing we can do is decrease the heart rate. Weird, right? That is what we see as a parasympathetic reflex from these baroreceptors. You're not going, in order to decrease the blood pressure, you need to somehow send that information to your sinoatrial node, right? This AV node does not activate the ventricles directly. It is the SA node doesn't activate the ventricles directly. It is the AV node that does. So if you can notice that this one goes only to the SA. This is, I want you to know this one as well for a test. This will, let me see. Right here's a better example of it. Alright, CNS medullary ischemic response. And they start talking about it here. Results from high carbon dioxide or low pH levels in the medulla, and it causes an increased peripheral resistance. This is the reason why blood pressure increases when we have a CVA. In other words, when we have somebody that goes into an ER and their blood pressure, for some reason or another, is at 180 over 120, really high, we know that it could be a sign of a CVA, of a stroke or an aneurysm. It's, right? Now the big thing is this, and I want you to understand this. It's a sign of that. It's not a cause of that. The cause is a blood clot, right? The blood pressure increase is a sign of that blood clot. And the reason why we never, at that point, sorry, it should be in this one, all right? We never decrease blood pressure at that point is this, right? Again, elevation of blood pressure in response to lack of blood flow to the medulla. Neurons of the vasomotor center become strongly stimulated, causing your, right, arteries in your muscles, all right, all the arteries in your body to constrict a little bit. Why? So then you can pressurize the blood, so then you can force blood through that narrowed blood vessel, right? Normally you have a blood vessel that's open. Doesn't take a lot of pressure to force blood through there. And now you have a clot in there. Because you have a clot there, you need to somehow bring blood past that clot. So what do? The only thing we can do is to pressurize the blood even more. As we pressurize it, we can hopefully move as much blood as possible past that narrowed opening. And the problem with it is this, right? So I know it's in terms of the CNS medullary ischemic response, functions in response to emergency situations, causing massive activation of our sympathetic motor system. What would happen if I drop blood pressure at this point? And this was I did see this when I was an intern, my first year at Cook County Hospital, right? We have somebody going into the ER and the nurse measured the blood pressure at like 200 over 160, some huge number. And I'm like, oh my God, that's huge. How does he? And I'm thinking to myself, I'm like, 200 over 160. There's no way that person is sitting here talking to us, right, without any kind of stroke effects. So I checked it myself, right? I checked it, and 205 over 160. I'm like, oh, that's not good. And then my attending checked it because he couldn't believe it. So he checked it, and it was 205 over 160. In other words, that's his real blood pressure at that time. And we were able to talk with him, and he did not mention any paralysis. We didn't see any paralysis, and no paresthesia on any side. No slurring of speech, no loss of consciousness. Again, you should not have pain when you have a stroke, right? That you shouldn't have pain. What we should have is loss of function on one side, loss of sensation, or slurred speech, right? Well, didn't have any of that. So what do? Do we just drop his blood pressure? No, right? What we did then was just observe him. So then we observe them, and then if in 2-3 days it's still high, then we slowly drop it. But if we would drop it acutely at that point, that could be the only reason why he wasn't having stroke symptoms. Because his body's doing all it can at that point to eject blood against that very narrow blood vessel. So the blood pressure allowed blood to move through that narrowed opening. So they have at least some blood flow. If it would decrease the blood pressure, you have less blood going through that opening now. If you decrease it even more, you're gonna have no blood going through. And you are going to create problems, and you're gonna cause them to really stroke out. So what we did was we put him in OBS, right, for a day, make sure that the blood pressure, that he didn't have any stroke symptoms. And then after 2 days of this, we slowly decreased the blood pressure as we found out that he really wasn't having that stroke. But we don't ever just decrease it suddenly. And again, and you will, it's normal to panic when it's your parents, right? I had it happen to my dad. My dad had a stroke when I was in medical school. So I understand, right? But then when it does happen to your parent, you have to understand as well that it's not the blood pressure that's causing the stroke. It is the actual clot that's causing an increase in blood pressure. The high blood pressure is a sign of a stroke. All right, now the rest of this, the renin, angiotensin, aldosterone, vasopressin mechanism, right, we're going to discuss, but we're going to go into it a lot more detail in chapter 25 and 26. So when we talk about this system right here, renin, angiotensinogen, aldosterone, how many people have family members that have high blood pressure? Should be just about everybody, right? What we're going to see is 99% of high blood pressure is idiopathic. We don't know the cause. We're just treating the symptom. So what we're going to do is this, right? We're going to start to see what kind of symptoms we can treat. In other words, we're going to take a guess at what we can do. We can give you a beta blocker. By giving you a beta blocker, I decrease the activity of the sympathetic nervous system, right? So then your heart doesn't contract with the same amount of force. So then I can increase your vasodilation. Or I can give you something that will do this. All right, some of you guys have heard of an ACE inhibitor. There are ACE inhibitors, and then there are also things that we call angiotensin receptor blockers, right? So what we're going to see is that there are a whole lot of antihypertensives, not just beta blockers. Beta blockers like propranolol was one of the first ones we used, but now we have a lot of calcium channel blockers, and then we have these, right? Something called an ACE inhibitor. And here's how ACE works. And what is ACE right here? Now, normally when we have a drop in blood pressure, this is during normal physiological circumstances, right? For some reason, you're dehydrated, your blood pressure drops. It causes your kidneys to release something called renin, a hormone called renin. Renin is important because of this, right? Throughout our body, we have these hormones, just like clotting factors. These hormones are produced, they're already in your bloodstream, inactive, right? We had those clotting factors, all 13 of them, that were produced, and now they were inactive until the first clotting factor activates. Well, we have the same thing here, right? We have something called Angiotensinogen. Anything that ends with a GEN usually is produced inactive. You're going to see a lot more of these when we talk about the pancreas, right? So angiotensinogen is not active. It's floating around, and usually it's made a little bit too long. It's a protein with too many amino acids on it. So this angiotensinogen, always around. And now, with a drop in blood pressure, that renin causes the first reaction where we start chopping off some of the amino acids. So angiotensinogen turns then into angiotensin 1. And again, think of the name, angiotensin. Sounds like angiotension, right? So what it's going to do is tense your blood vessels, increasing your blood pressure. Why? because that's a stimulus, a drop in blood pressure. Now, angiotensin 1 goes into the lungs. In the lungs, you have a hormone called ACE. Angiotensin converting enzyme. ACE. Right? ACE converts angiotensin 1 to angiotensin 2. And angiotensin 2 is a very potent vasoconstrictor, allowing us to regulate our blood pressure. Now, ACE inhibitors block this hormone, this enzyme. As you block this enzyme, we don't form angiotensin 2, the very potent form, right? Hopefully, by blocking it, we don't have this being formed. Your blood pressure will drop as a result. Again, it's all a slight guessing game, isn't it? There's another one that are our, right, angiotensin receptor blockers. That's your losartan, right? What happens is, yeah, we don't block the formation of angiotensin, but we block the receptors that angiotensin work on. By blocking those receptors, angiotensin can't function. When that is a problem, then your blood pressure will hopefully normalize. Again, a lot of this is trial and error. So then we figure out which one of these actually lower your blood pressure the best, right?
So those will be all guesses,
Was that?
like guesses?
Yeah, trial and error, all right? It's all it, right? Now, usually we know certain population groups, for some reason, they're more refractory to it. So African Americans, we usually don't use ACE inhibitors. So we don't, and the reason why is because in some population of African American females specifically, they can have something, an autoimmune disease, right, called sarcoidosis, and that can really affect the lung matter, and they're not, if I give you an ACE inhibitor, well, normally you don't have ACE to begin with. So if I give you an ACE inhibitor, it really doesn't help because your blood pressure is not due to this whole system, right? Your blood pressure will still be high, in other words. So we'll give you like a calcium channel blocker. But it is like almost a guessing game. And that's why you need to get it checked again and again. So then if it's not dropping, it's still high, they will either put another medication on you or they will change medications. And then check to see if that works, right?
They just experimenting on people and stuff.
No, it's everybody's different, right? Everybody's different. We say that, but but when
Okay,
people, it doesn't work, But yeah, it is, everything is just different for everybody. The ADH, so ACE inhibitors, antidiuretic hormone, right, or vasopressin. You guys know a diuretic makes you pee. So ADH is an antidiuretic hormone. It decreases urine volume. Normally, ADH will only be released when you have low blood pressure, so then you can maintain blood pressure by making sure you don't urinate, right? So ADH, antidiuretic hormone, will allow us to reabsorb more fluid in our kidneys. This is also the reason why when we start becoming severely dehydrated, we have so much ADH release that we don't form urine at all, right? And that's a bad sign, because now that you have so much water loss, your blood pressure is so low, we don't even bother producing urine. And if you don't produce urine for a few days, you will start building up urea and uric acid. And that will be bad, obviously. Right, now, the last one I'm going to talk about is this one, atrial natriuretic hormone. Now, the book switches between calling it atrial natriuretic hormone, atrial natriuretic protein, atrial natriuretic factor, right? So anytime you heard the first two letters or the first two words, it's the same thing. Atrial natriuretic peptide or hormone, released from your atrial cardiac muscles when blood pressure in the atria increase. Unlike these other two, right, with ACE inhibitors, with ADH, that's released when you are dehydrated, when your blood pressure is low. With ANH, it's released when your blood pressure is high, right? When you have a sudden increase in blood volume. And what it does then is it increases your urine output. So then you can pee out that excess amount of fluid. In other words, this is a complete opposite of the other two we just mentioned.